Greetings and welcome to today's On With Life webinar on preventing fall post-stroke. My name is Dave Clark. I'll be your host for today's event. Now, this is the third webinar in our series of stroke rehabilitation webinars. If you missed one of the earlier webinars, all of them are available on the On With Life website. There's no cost to view any of the webinars, and each webinar is good for 1 contact hour of CEU credit. After you viewed a webinar, just complete the evaluation form and you'll receive your certificate. All right, well, let's get started with today's presentation on Standing Tall, Preventing Fall Post-Stroke. Our presenter today is Andrea Cherry, a registered nurse at On With Life. Andrea has been a nurse for 3 years, and she's worked at On With Life for 1.5 years and is CBIS certified and MANT trained. Andrea will be leading us through the rest of the webinar as our featured presenter today. So Andrea, with that, take it away.
Hello, everyone. Like Dave said, my name is Andrea Cherry, and I'm a registered nurse here at On With Life. Today, we will be discussing fall prevention post-stroke. So the objectives for this presentation are as follows. 1, discuss fall percentages as it relates to the stroke population. 2, recognize 4 reasons for falls in the stroke population. 3, discuss 4 solutions to reduce falls for our stroke patient during the rehab process. And 4, discuss 2 possible teaching methods to educate patients or family members on the reduction of falls post-discharge. So some data that is out there related to the falls post-stroke. So the first one, up to 75% of stroke patients fall during their first 6 months post-injury. 40% of stroke patients experience serious falls within a year of their stroke. And then there is a study that reported falls to be the most common medical complication after a stroke. With the inpatient prevalence of falls during the acute hospital period post-stroke was 5%. The inpatient rehab environment is considered to be a high-risk environment for falls because the clinicians, the therapists are challenging the patient to achieve greater functional independence. And approximately 14% of stroke patients fall on an inpatient rehabilitation unit, despite the implementation of a prevention program. So why does a fall occur? There's a couple things. There is medical, physical, cognitive, and external, and we'll be going through each of these. First one is medical. So vestibular disorders. Vestibular disorders can affect parts of the inner ear and brain, which affects balance and eye movement. Signs and symptoms of the vestibular disorder include acute or chronic dizziness with positional changes or with movement. So an example of like the positional change is transferring, ambulating, anything that's they're changing a position. Example of movement is if there's in a seated position and people are moving past that individual, or if they're in a wheelchair and they're rolling past objects. That's when they experience that dizziness. Urinary disorders. The urinary disorders, there's multiple ones that can affect post-stroke patients. Frequency, nocturia, urgency, and incontinence are all linked to that increased risk for falls. It is also an important thing to consider that if a post-stroke patient is incontinent or they can't toilet themselves, that it can be an embarrassing position to be in, or they are uncomfortable with staff helping them in that position. So it is just important to keep an eye on that because the instance of them trying to do it themselves might increase that fall risk. Orthostatic hypotension. The definition of orthostatic hypotension is when the blood pressure drops when the patient goes from a lying position to either sitting or standing. So when that blood pressure drops, less blood flow goes into the organs, into the muscles. So because of that less blood blood flow that increase fall risk. Some signs and symptoms to watch out for orthostatic hypotension are dizziness, headache, change of vision, nausea, and weakness. Pain is also a fall risk. So post-stroke patients can present pain either immediately post-stroke, weeks, or months after the stroke. Everyone experiences pain differently. So according to the National Stroke Association, more than half of stroke survivors experience some sort of pain post-stroke. So the pain can interfere with activities of daily life, and then that can interfere with that increase with falls. Polypharmacy. So polypharmacy refers to taking 6 or more medications. So post-stroke patients require multiple medications to maintain that medical stability. With taking multiple medications, it can increase the risk for falls. The following medications contributes to the falls, and those are diuretics. If someone's having increased edema, diuretics are needed to get rid of that fluid. Vasodilators, which are for hypertension, beta blockers, insulin, antidepressants, psychotropics, and anticonvulsants. Those are all contributed to that increased risk for falls. So some of the physical causes of falls. So the first one is balance impairment. So the balance is comprised of vision, vestibular, and proprioception. If at least one of these are impaired, it increases that risk for a fall. Post-stroke patients often experience hemiparesis, which is the weakness on one side of the body. Due to that weakness, activities of daily life are affected. Muscle fatigue, lack of coordination, and loss of balance are all factors in the increased risk for falls. So decreased strength or impaired strength, it is linked to falls because of that limited use to weight bear. So if they try to get up, it's just hard to that weight bearing. The endurance, so endurance differs from person to person and time of day. So they could, in the afternoon, if they're getting tired, their endurance is decreased. And then range of motion, limited range to provide the stability causes those risks for falls. Increased muscle spasticity or muscle tone, they may cause increased balance issues or instability, which in turn increases that falls. Self-care deficit. So self-care deficit is unable to perform the following activities of daily life: hygiene, dressing, repositioning, anything that's like self-care. It's the inability to perform independently. And that's because of the impaired balance, the hemiparesis, decreased strength, or limited range of motion. Vision and perceptual changes. So vision is affected in about 2/3 of stroke patients. Types of vision loss includes loss of central vision, vision field loss, visual perceptual abnormalities, and eye movement abnormalities. So central vision is quite common post-stroke. Symptoms include the blurry or altered vision. Vision field loss is with the vision either lost in the right or left visual fields depending on the location of stroke. The post-stroke patients may not be aware of the visual field loss. They might bump into door frames, items on their affected side. So that's all increase in that falls because they're not seeing on that affected side. Visual perceptual deficits, they include neglect on one side of the body, difficulties with recognizing faces, difficulties with color vision, motion, or depth for perception. Eye movement abnormalities, difficulties with covering eyes, converging eyes to look at near objects, or double vision that's affected by the cranial nerves. Our cognitive, there's cognitive deficits. There's a few of them. The first one is aphasia. So aphasia is the difficulty expressing oneself, understanding others, or difficulty understanding the reading or writing. Memory loss is also included. It's the loss of nerve cells, and it can cause confusion or poor recall of events. Post-stroke patients may also experience poor insight into deficits and impaired safety awareness. Because of those poor insight into deficits, they are unaware that they're either the hemiparesis, the visual field loss, things of that nature, that they're thinking that they could get up and do things independently, but they do have those deficits. Impulsivity, a patient post-stroke may experience impulsive behavior, which is the lack of control of their actions or decisions or even words. The cognitive impairments may cause restlessness within that post-stroke patient. And because of the impulsivity and restlessness, they're wanting to get up independently. Post-stroke patients just are wanting to kind of stay active, so that's just increasing that fall risk. External causes. So the room layout, if a room is cluttered and does not have enough space to efficiently perform transfers, a fall may occur. The uneven floor surfaces or thresholds, either like pictured here, it's a smooth floor to a threshold to tile. So it is thresholds from room to room may pose a risk of tripping, which may increase that fall risk. And like I said, floor surfaces, so like here going from a smooth floor to a tile, or at home if it's a carpet to a tile or a wood, that's just a different type of different type of surfaces that can increase falls, the tripping hazards. Equipment, so the equipment includes the bed, assistive device, wheelchair setup. Those are all, if it's improper use of it, can increase the falls. Ill-fitting clothing, if they're too big of clothing and they're standing up to transfer, and then they are either the pants are just in the way of transferring, that can cause a tripping hazard and falls. Noise. So noise may cause post-stroke patients to become easily distracted and unable to concentrate. And then noise also interferes with sleep. So sleep fragmentation is also linked to increased fall risk. Lighting, improper lighting paired with post-stroke is, because of the vision changes, increases that fall risk if you have improper lighting. So what are the solutions to prevent these falls? The first one, if a fall occurs here on With Life, we have a fall huddle. So if someone falls, it's a transdisciplinary approach. We have all staff that was in the vicinity of the fall. We try to evaluate the cause, like what was the person served doing? Were they trying to go to the bathroom? Were they reaching for the call light? Were they, let's say, they were wanting a tissue but they couldn't find it? Any of those things, we were trying to pinpoint what they were doing. So after we know kind of what caused the fall, we could initiate some interventions. Some interventions might be to do 15-minute safety checks. So that's when we go around and just make sure that that person's service is safe. There is a seatbelt that will go more in depth later on. And then there's this other interventions that we can come up with. And like I said, it is transdisciplinary. So we do discuss with the medical director and our nurse practitioner, our therapists, to get the best intervention to reduce further falls. We also do vestibular testing and treatment. So once our therapists and our medical director decides that diagnose that it is vestibular, they do a treatment. And then we also assess for incontinence every 2 hours and offer the toilet or urinal prior to leaving the room. That is just to make sure that that incontinence if we could prevent that incontinence. Medication can also help with urinary disorders, urgency retention, and there is bladder training and a toilet schedule. So bladder training is to increase the amount of time between voiding and then the amount of fluid that the bladder can hold, just so that incontinence doesn't occur frequently. So orthostatic blood pressure assessments, the way we assess, we could do orthostatic blood pressures daily for X amount of days, just to assess if they are experiencing that orthostatic hypertension, and ways to treat or reduce effects of the orthostatic hypertension include medication management, and then having the person sort of pause and take their time with position changes. Effective pain relief from pharmacological, which would be oral medications or topical medications, and then non-pharmacological interventions. It would be the ice, heat, reposition. There's just make sure that they relieve pressure point areas, and then also kind of distract, put on their favorite TV show or music, things of that nature. Solutions to physical. So it is a transdisciplinary approach. So PT, OT, speech, they all work together. Therapeutic recreation, they all work together to improve that increasing that strength, balance, mobility, and then also teaching safe strategies for use of the assistive devices. They also do Berg assessments to evaluate the risk of falls. So the Berg is a balance, see how steady, unsteady they are on the feet, and they all work together to increase that mobility, strength, and balance. It is important that we provide proper placement of items prior to leaving room. And that's including the TV remote, any drink, hydration that they're wanting, a call light, tissues, or phone. Just make sure that they can reach everything prior to leaving. They also use a transfer checkoff list. So that is prior to the therapist making the person sort of independent with transfers. They want to have data to make sure that that person can transfer independently without any cues or assist of that staff. So what they do is they hang these checkoff lists in the room. So either it to be bed to wheelchair, wheelchair to toilet, wheelchair to bed. The staff has to observe 20 to 25 times and write down if they needed any cues or assist. Once they have enough data that the transfers did go okay without any assistance, then the therapist will make the person serve independent with transfers. Mass practice, kind of the same thing as just doing it over and over and over again, just to build up that strength and endurance. It is important to reduce those falls. They also do vision assessments. So vision assessments and treatments are like external cues, signs. They also do prism goggles. They're all used to help with that vision disorders. Solutions for cognitive, so I mentioned safety checks. So safety checks are, we check every 15 minutes on that individual. We make sure that they are safe. We make ourselves known. So they can always reach out to say if they need anything, if they need to use the restroom, or if they're in pain, or if they're cold, they can kind of count on us to kind of be there every 15 minutes. We also do one-to-one staffing. So one-to-one staffing is if that person is restless, impulsive, decreased safety awareness, we will provide a staff that's one-to-one with them throughout the shifts, just to decrease falls, decrease the incidence of a fall. We also try to anticipate needs. So that would be position change, personal needs, anything that they might need throughout the day. We kind of check in with them. Like I said before, like offer the toilet or urinal before leaving, just to kind of make sure that while the staff is there and available, we could get all their needs met. Again, mass practice. So this is like with space retrieval techniques, memory, visual tracking, any of those cognitive exercises. They just mass practice those. So this picture that is shown is the BITS. It's the BioNest Integrated Therapy System. So they are working on physical therapy as well as the memory, visual tracking, and sequencing. So redirection is important with fall reduction, making sure that a list that's readily available of interests, person serve favorite TV show or favorite music station, any games, or even just changing environment might help that fall reduction. A couple things that's shown here is a red stop sign over the seatbelt, and then also a pen release seatbelt. So these are ways to slow down the person serve. So if they are impulsive, decrease the safety awareness, they have a little extra barrier to get through than just unhooking a seatbelt and getting up. The stop is a visual thing that they could see to say, hey, stop, wait for assistance. And then the pin release seatbelt is just an extra barrier. So this provides time for staff to get to that person served, prevent that fall, meet their needs. If they need to go to the bathroom or if they need a position change, anything of that nature. These things our goal is to not restrain, but just to slow down that person serve. A dignity plan. So a dignity plan is a transdisciplinary approach, and it's applying safety strategies while maintaining the person served's dignity. So this plan is just ensuring that the whole team is applying the consistent strategies for that, either the impulsivity or decrease of safety awareness. So we're kind of all on the same page with that. Solutions to external. So the room layout is important. Here at On With Life, if we need to, we move beds, we move furniture, just to make sure that that room is safe. for transfers, for anything that, you know, the bedside table is on their unaffected side, so they could reach things like that, to just decrease those falls. Here shown is a room, and there's a tape line, outline of where the wheelchair should go in order for a transfer to the bed or bed to the wheelchair. That's just to make sure that we are doing a correct wheelchair setup. Assess surroundings. So we always just kind of glance at the whole room, making sure that there's no water on the floor. There's no clutter, anything that would impede those ease of transfers. Building safety checks to improve environment. So what they do is we go around, we make sure that the handrails are tight, they're not, you know, wobbly, and you know, the path is clear. There's nothing obstructing the path, that it could be a potential fall risk. We also educate on the proper use of assisted devices, whether it be the wheelchair, the walker, a walking cane, a cane. We're just making sure that that person served and their family members are knowing how to use those assisted devices. And then assess for a correct fit of clothing and footwear. That's just to prevent those tripping hazards. And then reduce noise. So either at shift change, in the middle of the night, just to kind of allow that person served to concentrate and not be distracted with noise. And then also maintain appropriate lighting. So making sure during transfers there's light, there's the lights are all working properly. The light bulbs are on, and doesn't need to be changed or anything. So the benefits of smart technology. So we are implementing some smart technology to reduce falls. The first one is our cloud camera to monitor the risk for fall. So if we have any impulsivity or a person served with decreased safety awareness, we could put that cloud camera in the room, and that's just to monitor the risk. So if someone's in the process of getting up or a fall risk, we could either come over the camera and say, you know, staff will be here shortly, and you could alert other staff to go to that room. The Amazon Echo Show is for patients to call for help if they're needing it, and for their loved ones to video drop in to check on them to see how they're doing. There's also glow-in-the-dark duct tape, and that's for pathfinding. So they'll put it along either thresholds or along the area, you know, to the bathroom, just to pathfind their way. Tile devices to locate items. That's, you know, just so they're not trying to get in situations to try to find like their TV remote or their phone. This tile device could just beep and find their items for them. Motion activated reminders. So this is one that you could put at, you know, like their doorway, or and just say, you know, once the motion is activated, it will be a verbal reminder, either, hey, wait for staff, or do you have your walker, do you have your cane? Just a reminder of fall reduction strategies. And then also for orientation, day clocks are used to just clearly display the day of week, time, or the date. So after a person served discharges, what education can we provide to decrease those falls in the home? So number one is just to make sure that they are continuing that participation for that task-specific exercises. That includes a home exercise program that they could do at home that family could help them with, and making sure that they are continuing that outpatient therapy for the recommended time frame. Adapting home to reduce fall risk. So that includes if they need to widen the door frames or change the layout of their bathroom or their kitchen. That's just adapting ways to reduce falls. Our PT and OT, they go on home evals prior to the person served discharging. And that's just to assess the safety and the setup of the home. They give recommendations of this assisted device or you know, to get kind of smooth the surfaces of the floors, no rugs. They just assess the whole home for safety to prevent falls. Educate proper use of assisted devices, so just making sure that person served and their family member are using the assisted devices correctly. And then educate the patient, the person served, on their deficits, vision, vestibular, proprioceptive, and how it would impact their balance and how that would increase the fall risk. So just making sure that the person served and their family member kind of understands those deficits. And then last, just educate the family on strategies to reduce falls, and then definitely supervision. If someone is impulsive and restless, you know, just to have that supervision there, just to see, making sure that those falls do reduce. Well, thank you so much. We have some time for questions. Back to you, Dave.
Thanks so much, Andrea. And as we transition to the Q&A segment of today's webinar, we have several questions queued up that have already been submitted. So, Andrea, let's get started with this question from Sue. Sue wants to know, what would be the appropriate intervention if a post-stroke patient experienced multiple falls?
That's a good question. So if the same person experienced multiple falls, it is definitely important to use that transdisciplinary approach, meet up with the therapist, medical director, the nurse practitioner, the nurses, the CNAs, just to kind of figure out why. Why is that person served having the multiple falls? So for example, if it's a cognitive impaired balance or the static hypertension, urinary disorders, just to make sure that we are finding that cause, and that post-fall huddle is important with that also. But if it is happening multiple times, we definitely need to find in either a different intervention, build on top of the intervention that was placed prior, just to make sure that we decrease the falls within that person, but then also maintaining the autonomy in that person. So whether it be that red stop sign on their seatbelt or a pin release, there's just making sure that we have the correct intervention.
All right, next up, let's go to a question from Tom. What education would be provided post-fall?
So if we have someone that fell, the first one is we maintain safety. So that's our most important thing, is we maintain safety. We do neuro checks. That's is the 15-minute neuro checks for a couple hours, and then it builds on top of that. So every half hour, every 8 hours, just to make sure that safety is maintained. But then it's the education part of it. So educating that person served regarding, calling for staff, regarding the deficits of either the vision, vestibular, or the proprioceptive. Just making sure that they understand kind of the diagnosis and then also the intervention that we're putting in place. Making, they have to kind of know, understand why we're checking on them every 15 minutes, why this seatbelt is a little different than what it was the day before, and then just making sure that the interventions and strategies are consistent.
And here's a question, Andrea, from Colleen. Colleen wants to know, would comorbidities increase the risk for falls?
Yes, it definitely would be increased risk. So with those comorbidities, so that's an example of someone had a stroke, but they also have diabetes, chronic kidney disease, COPD. With those, plus the impaired balance, impaired strength, increased muscle spasticity, especially decreased endurance, those just kind of combine onto that. So it is important to maintain the safety with those people. Like an example, if someone has COPD, they're kind of short of breath, they're going to have decreased endurance, which would pose a risk for falls.
All right, and I think we have time for one last question. This one's from Al. Al wants to know, what can family members do post-discharge to maintain safety for their loved one at home?
Yeah, so it is important for the family to be educated about their loved one's deficits and how that affects their balance, their strength, their endurance. And then also supervision is really important to decrease those falls in the home.
Okay, well, I think that is just about all the time we have for today's webinar. Thank you so much, Andrea. And again, you can access all of the prior webinars in this series from the On With Life website. All of the webinars are free to view, and each webinar is good for 1 contact hour of CEU credit. All you need to do is complete the post-webinar evaluation form to get your certificate. Thanks so much for being with us today. That does conclude today's webinar. Have a great day.